Good morning, everyone. I am Dr. Ramos Aguinaldo, and I will be your moderator for today's program. I would like to welcome everyone to this month's EHQUIP series entitled Dermatology Dialogues, Equipping Primary Health Caregivers on Contact Dermatitis, hosted by the Quirino Memorial Medical Center, Department of Dermatology. To ensure a smooth flow of our event and to minimize distractions, may we request everyone to turn off your microphones and cameras during the entire duration of the conference. We encourage you to kindly type in your questions and comments in the chat box during the lectures, and we will address them at the open forum. Here's an overview of today's program. Before we begin our lecture, may we first join together in a solemn prayer, followed by the singing of the Philippine National Anthem and QMMC hymn.
Mga kababayan, ang pambansang awit ng Pilipinas.
Kayang magiliw, helas ng sinakanan, alam ng puso, sa titik mo'y buhay. Lupang hinirang, tuyag ka ng magiting, sa mandulupin, di ka pasisingil, sa nagatang tutok sa simoy at sa langit ang bangaw, ay hinatang tula, kawin sa paglayang minamahal. Ang isang ng patawad mo'y tagumpay na nag-iindig, ang bituin at araw niya kailan pa may di magdidinig. Luman ang araw ng walang pagsinta, buhay langit sa piling mo. Aming ligaya na pagkay mga amin, ang mamatay ng dahil sa'yo.
Lilingkod sa kapwa, ang pangunahing tungkulin. Mahusay na programa sa pangkalusugan at iba yung pagkalinga. Mayaman man o mahirap, ay paglilingkuran ng sapat. Anumang sakit o malubhang karamdaman, ay bibigyan ng tiyak na lunas. Mula ngayon hanggang sa kinabukasan, tungkulin ay buong pusong gagampanan. Ito ang tapat at tanging sandigan Ito ang aming tanging layunin, mahusay at ligtas sa pagamutan, makabago at wastong kasangkapan, mga kawaning may sapat na kakayahan. Mula ngayon hanggang sa kinabukasan, tungkulin ay buong pusong gagampanan. Ito ang tapat at tanging sandigan. Sa QMMC ang bayan ay paglilingkuran. Mula ngayon hanggang sa kinabukasan, tungkulin ay buong pusong gagampanan. Ito ang tapat at tanging sandigan sa QMMC. Sa QMMC, sa QMMC ang bayan ay paglilingkuran.
Now, to begin our event, let us hear from our Medical Center Chief, Dr. Evelyn Victoria Reside, to give a few welcoming remarks.
Good morning, everyone, and welcome to another learning activity organized by QMMC's Professional Education Training and Research Office and our Department of Dermatology. I am Dr. Ivy Reside, and I am the Medical Center Chief of Quirino Memorial Medical Center. We continue our EHQUIP series as part of our hospital's commitment to engaging our healthcare partners in uplifting the standard of care within our provider network. We support efforts towards the sharing of knowledge and experience, all with the aim of ensuring that our patients and our communities receive only the best care possible. Today's topic is one that is close to my heart. Coming from a family with atopic conditions, it is not uncommon for us to deal with asthma, allergies, dermatitis, and rhinitis. We have all of these conditions in our family, so I personally understand how challenging it is to have this condition, what they call sakit na pangmayaman. Madalas na naming naririnig ang birong, kung Makati, edi kamutin. But for dermatitis, it really is not that simple. There is a whole lineup of treatment options available, which means that there are also a lot of diagnostic possibilities. And so please allow our experts to share knowledge and experience with you. Capitalize on this activity to review about the topic and to revitalize your love for learning. And if there should be further engagement with you and your facility, we can explore that as well, all for our patients. Again, congratulations to our organizing team from Petro and the Department of Dermatology under Dr. Hildegard Cabrera. And to our resource person, Dr. Janice Almeda, thank you for sharing your time and expertise. And to our participants, I wish you all a meaningful learning experience. Maraming salamat po.
Before we begin the lecture proper, please answer the short pretest with the link provided in the chat box, or you can scan this QR code. Our speaker for today is our very own consultant at Quirino Memorial Medical Center, Department of Dermatology. She is the head of the Patch Test Unit and Environmental Dermatitis here. She is a fellow of the Philippine Dermatological Society and a member of the Philippine Dermatological Society of Contact Dermatitis and Environmental Dermatitis. She is also a researcher at VMV Science and Research Center. She finished her dermatology residency at Skin and Cancer Foundation, Inc., and obtained her degree in medicine at De La Salle University Health Sciences Institute. Let us all welcome Dr. Janice Blandina E. Almeda.
Good morning, everyone. Thank you for attending today's EHQUIP series. I am Dr. Janice Almeda from the Department of Dermatology of Quirino Memorial Medical Center, and I will be discussing the basics of contact dermatitis. Let's begin with the skin. The skin is the body's largest and most visible organ. It is a complex and dynamic organ that serves many purposes, among which is maintenance of a physical barrier against heat and or cold, friction, UV irradiation, desiccation, burns, or irritants, and immunologic barrier against infections and allergens from the environment. Therefore, the skin is the first line of defense after exposure from these external elements. The protective and defensive function of the skin almost entirely belong to the epidermis. Its surface layer, the stratum corneum, and the hydrolipid layer is also known as the skin barrier. The skin barrier could be imagined as a brick wall with the skin cells as bricks and the natural oils or the lipid layer surrounding them as the cement. To keep healthy, the skin must be intact, as in its barrier function must not be compromised, as shown in the diagram on the left side of the slide. Breakdown of the skin barrier leads to dry, itchy skin, telling us that there is water being lost. This in turn leads to cracks in the skin, which allow easier penetration of irritants and allergens, as seen with the diagram on the right side of the slide. The brick wall image here shows that the bricks, which are actually the skin cells, have shrunk, and the cement, which is the natural oils of the skin, are depleted. The integrity and preserved functionality of the epidermal barrier are essential and are especially important for the occurrence of contact dermatitis, especially among healthcare workers who often are in contact with various substances. Contact dermatitis is known to be one of the most common inflammatory skin diseases to occur after contact with irritants or allergens. It includes two types: irritant or non-allergic contact dermatitis or ICD, and allergic contact dermatitis or ACD, both of which can have a clinical course in either acute or chronic form. ICD accounts for approximately 70 to 80% of contact dermatitis cases, while ACD is less common. The hands are the most common location of contact dermatitis. In the general population, the frequency of hand eczema is about 4% and is more common in women than in men. However, the incidence is increased in healthcare workers. It ranges from 0.6 to 6.7 per 10,000 person years. Irritant contact dermatitis or ICD is a localized inflammatory non-allergic skin response to several different chemical or physical factors such as the physical and chemical properties of irritants, host sensitivity factors, and environmental factors. It results from direct cytotoxicity and, as mentioned, is not immune-mediated. The factors which determine the severity of ICD include the quantity and concentration of the irritant. For example, the greater the amount of the irritant or the more concentrated it is, the more damage it causes the skin. Another is the duration and frequency of exposure, which is also directly proportional to the severity. It also depends on the type of skin of the patient. Thin skin is more prone to damage than thicker skin, areas such as the palms and soles, dry skin is easier penetrated by irritants and is damaged more severely than oily skin. Same goes with the very fair skin and those with pre-existing atopic tendency. The environmental factors that affect the skin response to irritants are the following. High temperatures and increased airflow reduces the epidermal barrier function and increases the penetration of irritants, while low humidity and temperatures increase transepidermal water loss and skin sensitivity to irritants. Increased skin moisture, such as wetting due to prolonged wearing of gloves, can also disrupt the epidermal barrier and intensify the inflammatory response to chemical or mechanical irritants. These are some common household products used for cleaning the house. They contain irritants. The common irritants are solvents, oxidizing agents, strong acids, or alkaline solutions. Solvents contain benzene, toluene, acetone, trichloroethylene, methyl ethyl ketone, or hexane, which are substances stronger than alcohol. They are used to remove unwanted smell, dust, dirt, or stains from surfaces. They are also found in detergents used for the laundry. They remove the skin's lipids and hygroscopic substances on the epidermal surface, denature proteins, and damage cell membranes. Oxidizing agents like sodium hypochlorite and benzoyl peroxide have cytotoxic effect. Example is Clorox or Zonrox, which are bleaching agents containing 7.5% sodium hypochlorite. Strong acids cause protein clotting and cell necrosis. Example is hydrochloric acid, also called muriatic acid, and sulfuric acid, commonly used for cleaning toilet bowls and declogging water drainage. Alkaline solutions saponify surface lipids, dissolve water-retaining substances, break keratin bands, and cause cell swelling. Examples include soaps, ammonia, potassium, and sodium hydroxide, cement, and chalk. Water is also a very common irritant. Prolonged contact of water on intact skin causes swelling of the corneocytes, disruption of the intercellular lipids, and an increased skin permeability and sensitivity to irritants. Since water is hypotonic, it acts as a cytotoxic agent on eroded skin. Another common irritant is wet work, defined as prolonged skin exposure to liquids, or wearing occlusive gloves for more than 2 hours a day, or washing or disinfecting hands more than 20 times a day. Example of occupations involving wet work include healthcare workers, hairdressers, cleaners, and cooks. Physical irritants, on the other hand, such as metal tools, wood, plastic, plant parts, paper or dust and soil, cause chronic microtrauma or friction and damage the epidermis, disrupt the epidermal barrier, and promote the release of pre-synthesized cytokines in keratinocytes. Physical irritants can act synergistically with chemical irritants such as detergents in water, causing serious disruption of the epidermal barrier. Initial development of ICD is damage to the epidermal barrier, resulting in higher skin permeability to external substances and transepidermal water loss, making the skin have a lower natural hydrating factor. Let's take, for example, a less potent irritant like sodium lauryl, which is a common ingredient in your soaps, shampoos, and conditioners. In experimental animals and human models subjected to daily use of sodium lauryl, caused acute epidermal damage by stimulating keratinocytes to release cytokines like your interleukins 1 alpha, 1 beta, and 6, and tumor necrosis factor alpha, which act as primary signals for the release of pro-inflammatory chemokines. Chemokines attract mononuclear and polymorphonuclear cells to the sites of injury, causing the inflammatory reaction. The diagnosis of ICD is mainly based on the clinical findings of a localized dermatitis in patients with a history of exposure to chemical or physical irritants. Irritants can be transferred to other areas of the body through contaminated hands or clothing. Important aspects to consider also in the patient's history include daily activities and/or the patient's occupation. Example is a laundry woman exposed to detergents and wet work. You should also ask about the types of substances or machines used at the workplace, working environment, wet work, or if the patient has an existing atopy or other inflammatory skin diseases. Additional clinical signs and symptoms that are beneficial to the diagnosis of ICD include the onset of symptoms within minutes to a few hours from exposure, pain, burning sensation, prickling, or discomfort that goes beyond itching, a shiny or smooth, dried or burned looking skin, peeling, hyperkeratosis or thickening of the skin, or vesicular lesions. Patch testing is recommended to rule out ACD. ICD should be treated as soon as it is recognized. All irritants should be avoided as this is the best treatment option. Some emollients, usually with high lipid content including petrolatum, accelerate barrier repair. Topical corticosteroids may be given for a short course to decrease the inflammation. Alcohol-based hand sanitizers as a substitute for hand washing whenever allowed. Occlusive gloves should be used for wet work but only worn for the shortest possible time. In persons with pre-existing irritant dermatitis, cotton gloves are recommended under occlusive gloves if the duration of glove usage is more than 10 minutes. Refer to a dermatologist knowledgeable about patch testing for occupational contact dermatitis if there is no improvement 3 months after initial evaluation for dermatitis and if there is a suspicion of allergic contact dermatitis. Allergic contact dermatitis, or ACD, on the other hand, is a delayed cell-mediated hypersensitivity reaction or type 4 hypersensitivity reaction resulting from exposure and sensitization of a genetically susceptible host to an environmental allergen followed by subsequent re-exposure that triggers a complex inflammatory reaction appearing approximately 48 hours after repeated contact with an allergen. The clinical manifestation of allergic contact dermatitis is an eczematous dermatitis. The acute phase is characterized by pruritus, erythema, edema, and vesicles. In the subacute phase, vesicular rupture leads to oozing and scaly papules associated with whipping and crusting. The chronic phase is characterized by scaling, fissuring, and lichenification. A key symptom in ACD is pruritus. Itch and swelling are key components of the history and may be clues to allergy. The inflammatory response to eliminate antigen-modified keratinocytes results in loss of cell cohesion, vesiculation, destruction, and desquamation, thereby decreasing the inflammatory process. There are two distinct phases in the pathogenesis of ACD, the sensitization phase and the elicitation phase. In the sensitization phase, the initial step in development of ACD is hapten binding called protein haptenation. Haptens are basically unprocessed allergens. They are typically small lipophilic molecules with low molecular weight that are able to penetrate the stratum corneum barrier of the skin. They are essentially incomplete antigens, having the property of antigenicity but not immunogenicity, meaning they can elicit an immune response only when attached to a large carrier protein. The haptens penetrate the skin, binds with epidermal carrier proteins to form the hapten protein complex and form a complete antigen. Next, the antigen-presenting cells, or APC, of the skin, which are the Langerhans cells or dermal dendritic cells, take up the antigen, or the hapten protein complex, and expresses it on its cell surface. The APC migrates via lymphatics to regional lymph nodes, particularly at the paracortical areas. The antigens taken up by the APC then come in contact with naive antigen-specific T cells. These naive T cells are primed and differentiate into memory or effector T cells, which expand clonally, acquire skin-specific homing antigens, and travel through the blood where they act as effectors on target cells presenting the same antigen in the future. The sensitization phase lasts 10 to 15 days and is asymptomatic. Memory T cells can be recruited from the circulation to the skin during the elicitation phase. Subsequent exposure to the antigen to which the patient is already sensitized, or what is also called re-challenge, amplify the immune response with the release of cytokines and chemokines, leading to clinical disease. The diagnosis of ACD includes a careful medical and environmental exposure history, history of present illness, site or sites of onset of itch or rash, topical agents used, history of endogenous skin diseases, and the patient's general health, detailed usage of personal care products, and the patient's occupation history. Most of the time, an exact cause cannot be identified based on history and examination alone. The topographic approach in the diagnosis of ACD is based on the distribution of dermatitis on the patient's skin and is useful guide in patch testing. Another approach is the allergen-specific approach. Metals are a common cause of ACD. Nickel is the most frequent patch test positive allergen worldwide, with a sensitization rate of 18% to 30%. Thiram mix, mercaptan mix, and isopropyl and phenyl 4-phenyldiamine and carbamix are found in rubber products. Sesquiterpene is found in fragrances and in some varieties of plants. These allergens are found in the patch test kit. We have the 30 series where the kit has 30 allergens or haptens. There is also the 80 series with 80 haptens contained in the patch test kit. Using the topographic approach in the diagnosis of this rash on the waist area of this male patient, you probably would assume that the buckle of the belt is the cause of the rash. But even the most intuitive assumption of a rash reaction on the belt area, probably due to the buckle of the belt or an allergy to nickel, is incorrect more than 50% of the time. Patch testing is done to confirm the diagnosis. The diagnosis of ACD is usually well established by a combination of history and physical examination, clinical presentation, and a positive patch test. If further evaluation is required, a skin biopsy of an affected area is done. ACD will typically demonstrate spongiosis. However, this finding is unlikely to facilitate demonstration of ACD from other eczematous dermatitis disorders. When a patient then presents with a rash on the ring finger, Is it ACD to the ring or ICD to water that is constantly trapped in between the ring and the skin of this patient who frequently washes his hands and maybe does not dry his hands well enough? This table shows the comparison of the symptoms of ACD and ICD. In allergic contact dermatitis, even a minute amount of the causative agent can elicit a skin reaction on the site of exposure and even spread to other parts of the body, usually 2 to 3 days after exposure in a sensitized individual. In irritant contact dermatitis, the inflammatory response is rapid in minutes to a few hours after exposure to the causative agent. The inflammatory response is strictly confined to the site of exposure to a strong chemical. This may occur in practically everyone. Do you still need to patch test it? If possible, yes. Patch testing is the gold standard to diagnose ACD, which is performed under standard conditions. It is intended to produce a local allergic reaction on a small area, usually the back, where the standard allergens are planted. Who do we patch test? Patients suspected with ACD, any endogenous dermatitis which has not otherwise been diagnosed, not resolving within 6 weeks despite proper management, any chronic hand and foot eczema, any diagnosed endogenous dermatitis with unexplained, uncontrolled flare-ups, wherein subsequent ACD can develop as a secondary phenomenon in the course of the primary dermatosis, or any unexplained dermatitis with nonspecific signs and symptoms such as pruritus, rash, erosions, or papular eruptions. Patch testing, however, is contraindicated in patients with the following: immune deficiencies and autoimmune diseases, because they may exacerbate the allergic response to patch testing. Patients undergoing immunosuppressive treatment may cause false positive or false negative results, and pregnancy and lactation. Allow me to discuss very shortly the procedure of patch testing. First is the preparation of materials needed. This is a panel consisting of individual chambers. The characteristics of the panel are the following. It is inert, meaning it does not interfere with the haptens. It is not allergenic, and that it provides good occlusion. These are haptens contained in syringes or bottle droppers. The ones that are in syringes are non-volatile haptens, meaning they do not vaporize rapidly. They have preload capability up to 2 weeks if stored properly in the refrigerator. And the ones in dropper bottles are volatile or liquid haptens and cannot be preloaded because they vaporize rapidly. This is how we load the different haptens in their respective chambers. We also need marker pens, which are hypoallergenic, and additional tape to secure the panels. Next is the preparation of the patient. The patient's back is the preferred site for patch testing. It should be clean, dry, and clear of any dermatitis. Excessive hair, usually in males, must be trimmed. The back is preferred for patch testing because it is flat and provides good occlusion. It is large enough for the placement of the panels. It is not regularly exposed to the sun and is less prone to scratching. But other sites may be used if the back cannot be used. Other sites are the outer surface of the upper arms, thighs, flanks, and abdomen. Here are some guides before patch testing. The patient is instructed not to tan or have phototherapy treatment for 2 weeks before patch testing. Patients on corticosteroid therapy should be reduced to 15 milligrams of prednisone, equivalent to 1 week prior to patch testing. Patient is also asked to bring their skin products, wash products, etc., and to note the ingredients on the label. On the patch test week, Monday, Wednesday, and Friday is the best schedule for the patch test procedure. Patient may shower on Monday before the patch test but should be advised not to apply anything on the skin after. Antihistamines are allowed to be taken up to 2 pills twice daily. Topical steroids may be used on parts of the body not being tested. Patient is also reminded not to swim, exercise, or do any sweat-inducing activities for the week and to wear loose-fitting clothes. The third step is the application of the patch test panel. The upper back is used with the patient on a slight hunched-over posture, avoiding to use the area over the vertebrae because false positive reactions can result. The panel is adhered from the top portion, applying slight pressure downwards to express air and to distribute allergens evenly. Each strip is outlined with a marker to know the placement of the chambers, just in case the panels are slightly displaced. On Wednesday, 48 hours after, the patch panels are gently removed, allowing 15 to 30 minutes rest for the transient erythema caused by the occlusive effects of the allergens and the tape to subside. The corner borders of each chamber are marked as guide for reading. Positive patch test reactions are graded on a quantitative scale using this patch test reading plate adopted by the International Contact Dermatitis Research Group. No reaction is read as a negative reaction. A faint macular erythema is read as a doubtful reaction. Erythema, infiltration, and positive papules is given a +1, read as a weak positive reaction. Erythema, infiltration, papules, and vesicles is given a grade of +2, read as a strong positive reaction. Bull's reaction is given a +3, read as an extreme positive reaction. IR for irritant reaction shows shiny, wrinkled macule without erythema. NT stands for not tested. The initial reading is at 48 hours after patch placement, and final reading is around 96 hours after. Relevance must be qualified as possible if, for example, a patient has a positive patch test to Carbamix. Carbamix is usually contained in rubber products, and patient tells you he remembers wearing his new rubber shoes, for example, when the rashes appeared. Probable if the patient has a positive patch test reaction to Carbamix and said it appeared when patient used rubber gloves and then noticed the itchy rashes. Relevance of a positive patch test is only determined with certainty if the dermatitis clears with avoidance of the allergen and relapses upon re-exposure to it. Some patients may develop these reactions to patch testing. Irritant reactions are more often seen with a non-standard allergen for patch testing. Ectopic flare of dermatitis with an existing or pre-existing dermatitis. Koebner phenomenon in patients with psoriasis, vitiligo, or lichen planus. Persistence of a positive reaction, such as for gold, persisting for many months. Alteration in pigmentation, which is infrequent and is most likely in dark-skinned patients. Adhesive tape reactions, which is almost always irritant. Anaphylactoid reaction is rare, which may occur 30 minutes after topical testing with certain antibiotics like penicillin, gentamicin, or bacitracin. Edge effect is an irritant reaction which is greatest at the periphery and none in the center of the patch test. Pustular reaction, especially in atopic persons, from metallic salts. Pressure effects, especially with dermatographism. Bacterial, fungal, or viral infections is not really encountered, but is possible with plant parts. Necrosis, scarring, and keloid are seen with strong chemicals of unknown composition. This photo shows an irritant reaction from the tape, showing sharp demarcation at the edge of where the tape had been applied. Allergy to tape is exceedingly rare and is almost always irritant reactions. The following are the significance of patch testing. A higher percentage of having a final diagnosis, which is 88% compared to 69% among those not tested, and more than 20 times shorter time lapse from the first visit to the final diagnosis, like from 175 days without patch testing to 8 days only with patch testing. Having a patch test better helps control symptoms of the allergy because patients should avoid products containing the allergen. It also reduces treatment cost and improves the quality of life. For the prognosis of ACD, the disease stays with affected populations throughout their lives.
Patient education is important because the only definitive treatment of ACD is the identification and removal of the offending agent, and all patients with suspected or confirmed ACD should be advised of this.
The first line of treatment is the use of topical steroids if body involvement is less than 20%, or oral corticosteroids if body involvement is greater than 20%. This is given at 1 mg per kilogram per day for 1 week, tapering weekly for 3 to 4 weeks. Topical calcineurin inhibitors for delicate areas such as the skin folds or eyelids. The DOH Consensus Panel advocates the use of narrowband phototherapy as adjunct for chronic recalcitrant contact dermatitis. The DOH Consensus Panel unanimously voted against the use of systemic immunosuppressives such as methotrexate, azathioprine, cyclosporine, mycophenolate mofetil, and JAK inhibitors, citing insufficient evidence of benefits when compared to the use of oral corticosteroids. Moreover, immunosuppressives are generally more costly than oral corticosteroids, particularly when used for chronic conditions. Patient education is to make sure that the allergens are avoided. Monitoring of the patient every 1 to 2 months for improvement. And to repair the damaged skin barrier with emollients and the use of mild soaps or substituting hand sanitizers instead of soap and water. Alcohol sanitizers does not damage the lipid layer of the skin as compared to washing with soap and water. And I end my slide with this skin quote. Your skin is an investment, not an expense. Thank you everyone for listening.
Thank you very much, Dr. Almeda, for that timely and relevant lecture. Surely everyone has learned a lot. Now, here's how we conduct patch testing at our very own Quirino Memorial Medical Center, Department of Dermatology. We will now open the floor for questions from the audience. Hi, Doctora. There's a question here. What are the most common allergens in general?
In general, it is still the nickel. Tapos, meron rin about mga preservatives like formaldehyde and fragrances. Yung nickel kasi, madaming sources pala yung nickel. It's not only the ones in your watches or your earrings. Meron rin sa food, like your root crops, like potatoes, onions, and yung garlic, chocolates. Yeah. Those are the sources of nickel. So even in our institution at Quirino, where we did patch testing, nickel pa rin is still number one allergen.
Okay, Doctora. There's a question here po sa Zoom. How to manage po if you have wet work and hindi maiwasan ang wear ng gloves? Thank you.
Pag wet work at hindi maiwasan ang pag-wear ng gloves, you can use yung cotton gloves underneath the rubber gloves. Tapos, you have to really remove it pag medyo longer than 2 hours na. And then, always apply your emollients before putting on your gloves.
Okay, Doctora. Thank you. There's another question po. Is dermatitis more dangerous as you grow older?
No. No naman. Kaya lang, no naman, if you have contact dermatitis, ang nangyayari niyaan, if on the another exposure, medyo pwedeng mas severe yung reaction. Pero as you grow older, maybe it's because your skin is already parang it lost already its parang the lipid content on your skin, kaya siguro mas yung allergen mas severe. It depends on the skin type. I mentioned that earlier. Yeah, it could be because of the skin is older and it has lost already its lipid content.
Okay, thank you po. And then, Doctora, there's another question. At what age can we do patch testing?
Pwede rin sa mga bata. You can do it as early as the mga children.
Okay.
7 years old, basta they are cooperative.
Okay, Doctora. And then, hi, Doc. What type of brand or laundry detergent would you recommend?
Oh. It depends talaga kasi all detergents contain an irritant. But if you are really allergic to that laundry detergent, yung mga powders, you can use Perla. Or there are baby detergents na rin for babies. You can use that if you're really allergic to the stronger ones. Or not allergic, but if it causes irritation.
Okay, Doctora. Thank you. And then there's another question po. Doctora, rejuvenating sets are common nowadays. Can they cause ACD din po?
Oh, yes. Kaya nga pinapadala namin yung mga cosmetics ninyo, yung mga wash products, so that we can see sa label. Dapat talagang you should practice reading your labels kasi pwedeng doon sa mga ingredients na yun, isa sa mga doon, meron kang allergy.
Okay, Doctora. Thank you. And then, can applying moisturizer or lotion help prevent dermatitis?
Yes. Di ba you remember the skin barrier? So, pag kasi medyo dry yung skin, tapos mas madali siyang pasukan ng mga irritants or allergens. Kaya yung pag-apply mo ng lotion is talagang dapat regular. Yung tip ko is that after washing your hands, you pat dry, tapos apply mo kaagad yung lotion mo para natatrap doon yung moisture. Or pwede ka rin maglagay muna ng oil tapos yung lotion.
Okay, Doc. Thank you. Are there specific products or materials that primary caregivers should avoid to prevent contact dermatitis?
We cannot really know, no? Unless na patch test ka and kunwari sa gloves and you are allergic to the rubber gloves, yung latex, we can recommend the nitrile gloves, which is also naman good enough. It's a synthetic rubber.
Okay, Doc. There's a question, Doc, from Facebook Live.
Mhm.
What is the difference of ointment and cream, and can stress trigger dermatitis?
Ointment is used for dry dermatitis, yung dry dermatitis, skin conditions. Tapos, the cream is for the wet ones.
And then
What,
can stress trigger dermatitis?
pwede rin, kasi in the patch test kit, meron din doon na about mga medications na like budesonide is, I think, a steroid cream, no? It can also trigger dermatitis, allergic dermatitis.
Okay, Doc. There's a question here, is patch testing expensive po?
Oh no. Sa yes, in private hospitals, in private clinics, it's quite expensive. Pero sa mga government hospitals like in Quirino, it is affordable naman.
Okay, Doc. And then for contact dermatitis, are there any advisable home remedies for this, if ever?
Home remedies for contact dermatitis. Well, yung tungkol sa wet work, tayong mga mothers, di ba? Palaging nag-wash, palaging naghugas ng pinggan. Well, you always try to um, use lotions. Di ba dapat hindi mako-compromise yung skin barrier mo, di ba? The lipid content and yung mga keratinocytes, dapat hindi siya matuyuan. So, always use your lotions.
Okay, Doc. And then another question, is it possible na mag-react ang skin sa isang product even after using for a long time? That's what happened to my face after using Kojic.
Kojic. You have been using Kojic
Is it possible daw, Doctor?
na for a long time and then you develop
Yes, ma'am.
dermatitis.
Opo, yes.
Oo. Probably irritant na yun. You should stop it na. Cause yung allergic reaction, yung unang gamit mo, tapos ginamit mo the second time, magkakaroon na ng itchiness and kunwari erythema, medyo may mga butlig-butlig. Pero yung irritant, it's not sometimes it's not itchy. Tapos it's due to the amount that you applied or the frequency, yung ang tagal-tagal mo nang ginagamit. Yun, pwedeng irritation na yun.
Okay, Doc. And then connected din po sa dermatitis kapag allergy sa food.
Yung food allergy kasi, ibang klaseng 'di ba? Ibang klaseng hypersensitivity reaction 'yon. 'Di ba? Ang contact dermatitis is type 4 hypersensitivity reaction. It's cell-mediated. Pero yung food allergy, usually yan, buong katawan, tsaka may urticaria, yung mga, parang, anong tawag doon? Urticaria, type 1 yan, hypersensitivity reaction. So, para malaman mo kung kung anong test ang gagawin doon is yung yung food challenge. Yan ang mas maganda.
Okay, Doc. Doc, okay lang ba lagyan ng baby powder or face powder yung kamay before gumamit ng rubber gloves or sterile gloves?
Bakit? Pawisin ba yung kamay mo? So,
Yeah.
pwede siguro kung hindi ka naman hindi ka allergic doon, pwede.
Okay, Doc. And then, possible po ba, Doc, allergy tayo sa sariling pawis natin?
Sariling pawis natin, malamang hindi allergy yon kasi ang pawis palagi naman nasa katawan yun, ano? Hindi. Hindi siya, ang nagkakaroon, ang alam ko, yung mas nangangating balat dahil sa pawis is yung mga may atopic dermatitis. Mas matindi yung pangangati nila pag pinapawisan sila.
Okay, Doc. And is benzoyl peroxide soap like Katialis is safe to use daily?
Benzoyl peroxide for the pimples.
And Katialis, safe to use daily?
Yung benzoyl peroxide, we only prescribe it pagka yung pimple is really big and then spot treatment lang siya. And then the Katialis, I think, hindi namin yan ginagamit. Medyo nakaka-cause siya ng irritation also.
Opo. And then, how accurate po yung test? And ano pong difference between patch test versus skin allergy? I think, Doc, yung skin prick to. Skin prick testing.
Oo. Yung skin prick test, ginagamit yan sa type 1, yung sa food allergy. Yung patch test, yung lumalabas sa balat, yung if you come in contact with a substance and it causes reaction, ipapatch test ka kasi parang meron kang allergy doon. Yung patch test, talagang accurate yon. May scientific basis yon under controlled or standard conditions na fina-follow.
Okay, Doc. And then there's question here sa Facebook. Is there a specific training for nurses before doing the procedure of patch test?
Yes.
And then, is contact dermatitis same as asthma? Or I think atopic dermatitis yung tinatanong nila.
Hindi. Magkaiba sila. Pero yung pwede silang mag-occur together. Like kung kunwari meron kang atopic, tapos hindi kahit na anong treatment mo hindi siya gumagaling, you think of allergic contact dermatitis or irritant contact dermatitis. Tapos papatch test ka. Tapos if there is talaga naalis yung allergen na yon, yung allergen na yon, and then mas ma-i-improve yung atopic skin mo.
Yes, Doc. And then, another question, Doc. Can dermatitis cause permanent scar or may long-time complications ba ang contact dermatitis?
Pag kinamot mo, magkakaroon ka ng, di ba, yung minention sa mga complications, pwede kang mag-scar. Pag talagang nakamot mo or lumalim yung sugat, no, pwede kang magkaroon ng scar. Kaya lang, that's very rare.
Okay, Doc. There are lots of questions about treatment, Doc, here. I think they should contact our department na lang for the treatments.
Okay.
Yeah, because it's not in the scope. And then last question, Doc. How can we advise patients who still have contact dermatitis manifestations even after removing all known allergens?
How can we manage? Well, you better check kung kunwari meron pa rin siyang, baka na-remove mo na nga yung lahat ng allergens, pero you're still you can check on the irritants also. Baka palagi kang, di ba, wet work or yung water is a very common irritant. And yung ibang allergens, yung mga detergent soaps mo, yung pang-clean mo. And then, you can also check kung meron kang atopic dermatitis or other skin conditions. Ayun. And then, siguro pag manage mo, kasi minsan yung skin natin, nakakadagdag talaga yung dryness ng skin, yung cirrhosis. Pag dry yung skin, nakakadagdag talaga sa kate. So, you can apply liberal, lotion right after taking a bath
Okay,
or
Doc.
after washing your hands. Yan
Okay.
ang tip.
Okay, Doc. Thank you. So we have lots of questions here sa chat box and Facebook. So you can contact our Facebook page, QMMC Dermatology, if you have other questions. So that would be our last question, Doctora, for the forum. Thank you once again, Dr. Almeda, for imparting our knowledge to our audience.
Thank you.
Thank you, Doc. Now let us please answer this post-test link to check what we've learned from Dr. Almeda's very insightful lecture. Please click and answer the link provided in the chat box, or you can scan this QR code. Now we would like to present the certificate to Dr. Janice Blandina E. Almeda, for being the speaker at Dermatology Dialogues, equipping primary health caregivers on contact dermatitis at Quirino Memorial Medical Center, EHQUIP series given on this day, February 24, 2024.
Okay, thank you. I would like also to thank Dr. Reside and our chairman, Dr. Cabrera. Also, you, Dr. Ramos, for moderating, and my contact dermatitis team. Thank you. And of course, to all the participants who attended today's series. Thank you.
Thank you, Doc. Now let us hear from the chairman of the Department of Dermatology, Dr. Hildegard Cabrera, to give a few closing remarks for this event.
Thank you, Dr. Almeida, for a comprehensive lecture on contact dermatitis. It may sound simple that contact dermatitis is an allergy in response to an exposure to a certain chemical that touches our skin. However, finding the cause seems to be more challenging. Dermatologists race towards identifying the cause in order to prevent extensive complications. Here at the QMMC Department of Dermatology, we use patch testing as the key to better diagnosis and management of contact allergies. In behalf of the department, I am Dr. Hildegard Cabrera, Chairman of the Department of Dermatology, thanking you all, and I hope that we are able to shed light on contact dermatitis and patch testing as a valuable diagnostic tool. Have a good day, everyone.
Again, we would like to thank everyone for attending today's event, Dermatology Dialogues, equipping primary caregivers on contact dermatitis. We'd like to thank our Medical Center Chief, Dr. Reside, our Chairman, Dr. Cabrera, and of course, our resource speaker for giving her time and sharing her expertise on the matter, Dr. Almeida. Indeed, it was a morning of learning for all of us. May we be able to apply everything that we learned in our practice. Thank you very much and have a wonderful rest of the day.